Hello and welcome to USMMA EMS training online. Today we'll be going over a general approach to patient care. For starters, we have the definition of pediatrics. This is anyone who has not reached their 15th birthday. So 14, 13, 12, 11, 10, all the way down to 1 year old is considered a pediatric patient, and then 1 being an infant. Pediatrics will also be considered when you are dealing with patient less than 30 kilograms or 66 pounds. For administration of epinephrine. So you'll give them the pediatric dose if they are less than 66 pounds. General approach to patient care and EMS calls. We have standardized framework. Once you get the call, you get the toned out 9A. You consider the type of response, emergency, non-emergency. Location, mechanism of injury, nature of illness, number of patients, need for additional resources. Survey the scene, make sure it's safe. Make sure there's no hazards, mechanical, falling debris, chemical, smoke, inhalation, carbon monoxide. Also gauge a number of actual patients there and see if you need an MCI scene set up. ALS intercept is important. Law enforcement if need be. Ensure the precautions for PPE are equipped and manned. Everyone is donned PPE if necessary. Gowns, full face mask, gloves, boots, BDUs, all of the above, especially in COVID times. And for MCIs, put a command structure out. For the general approach, we have the history of patient illness. What events led up to the EMS call? Using sample and OPQRST, get the patient's general information. OPQRST and sample can give you a lot about the patient. Get the past medical history and get this, if you can, from family, bystanders, or roommates. To start, we have sample. Signs and symptoms. What do you observe? What does the patient tell you? Allergies, just as it sounds. Medication. They're taking anything right now. Past pertinent information. Last oral intake. This is important if they passed out. You say, did you eat or drink anything today? They say, no, I haven't eaten anything in 2 days, so that's probably why. Events leading up to the illness or the call, and what were you doing before this happened? And this is kind of a similar question for onset. What was the patient doing? Were they active, inactive, stressed out, taking a test, taking a nap? What was going on? Provocations and palliations. Fancy words for what makes it better or worse. Quality, typically asks, can you describe the pain for me? And if they need some help with the words, you can throw a few lines out there like, is it sharp pain? Is it crushing? Is it burning? But typically, you like to have the patient describe it in their own words. Region or radiating. Is it stationary or does the pain spread anywhere else? Severity. On a scale of 1 to 10, how bad is your pain? 1 being no pain, 10 being the worst pain you ever felt in your life. Timing. How long has this been going on for? And has it changed since? So moving on to physical examination. Get the chief complaint, get the mechanism of injury, and see if there's any medical tags. Typically for older patients, they'll be wearing wrist, maybe like this, or a metal chain around their neck. Airway. This is for a review for all my future EMTs out there. Is the airway patent? Will it stay open on its own? Do you need a OPA, oropharyngeal airway adjunct, NPA, nasopharyngeal airway adjunct? Do you need suction? Breathing. Is oxygen therapy necessary? Do you need to ventilate them? How is their SpO2? Is breathing present, too fast or too slow? Are they speaking effectively? Circulation. Is there any trauma or bleeding? Is a pulse present? Is the pulse too fast or too slow? Is it regular or irregular? How's the skin, color, temperature, condition? Serious hemorrhaging? That's that squirting arterial bleed. And are they suffering from any internal bleeding? Is there any signs of shock? Remember, cool, pale, and diaphoretic. Continuously monitor ABCs throughout your patient interaction. Any disabilities? So to discuss this, we have AVPU, alert. Remember ANO times 4, you ask your 4 questions. Are they alert to voice? You speak, you yell, and they open their eyes and they acknowledge you. Verbal, responsive to pain, pinch the trap, and they respond, or unresponsive. They don't respond to anything. Glasgow Coma Scale. Pupils, so what are their pupils like? And Cincinnati Stroke Scale. Expose the patient if necessary, but always protect them from public view. Secondary assessment, we have vital signs. That's pulse, respirations, always rate and quality for those two, blood pressure, skin, color, temperature, condition, and once we get our blood glucose monitor, we can use that. Contact medical control to give you any orders or anything within the scope of your practice that you're unsure of. Make a verbal report to the hospital and always complete a PCR. So ongoing scene assessment and patient assessment. Make sure you're continuously situationally aware. Make sure you're aware of all the things around you, especially the crew chief, but that also goes for everyone on the watch team. If you see you're going to get pinned in an area, or you're going to get stuck, or bus might flip, or tires might get in a mud situation, make sure everyone's working with each other and letting each other know. Contact medical control if you have questions. And this is the last little bit of the protocols. They changed it. You cannot have the child sitting in the mother's lap anymore. You have to restrain them. This is more so for vigilant. So when we ride vigilant buses, they have the patient restraint devices that they can use on the bus. Stay sharp and remember your training. Thank you all.